Hello medicos, today we will learn Gerd. First of all, factors helping in maintaining the patency of LES. The most important factor, the length of intra-abdominal esophagus. It is the most important factor which help in maintaining the LES or in preventing reflux. Normally, the length of intra-abdominal esophagus is 3 to 5 cm. The second factor, angle of His. It is gastroesophageal angle. The third factor, pinching effect of right diaphragmatic crura. And the fourth factor, which have least contribution, the arrangement of gastric folds. Gerd develop if length of intra-abdominal esophagus become less than 2 cm and pressure become less than 6 mm of Hg. Normally, the pressure of LES is 8 to 25 mm of Hg. Earliest physiological indicator of reflux is increase in transient lower esophagus pincher relaxation. Now, the clinical feature of Gerd. Here we see retrosternal burning sensation, that is heartburn, bad taste in oral cavity, pharyngitis, laryngitis, and dental caries. Investigation of Gerd. Investigation of choice is endoscopy. Gold standard is 24-hour pH monitoring. Indication for 24-hour pH monitoring is done where endoscopy is inconclusive or if patient is being planned for surgery. Here, pH probe is kept 5 cm proximal to gastroesophageal junction. If pH is less than 4 for greater than 4% time in 24-hour period, then it is Gerd. Demister score is used of greater than 14.7 is Gerd, is the indication of Gerd. Demister score. Other wireless method to measure Gerd is Bravo 24. Now, the management of Gerd. First of all, lifestyle changes. Avoid food particles which relax LES. Avoid chocolate, fried fatty food, spicy food, citrus food, tea or coffee. Small frequent meal should be taken. Have meals at least 24 hours before going to bed. Now, medicines. Prokinetic agent or PPI is used. Indication for surgery in Gerd. If patient fail to respond to medical therapy or if complication present like Barrett's is present, cancer or stricture is present, or if it is associated with a hiatal hernia. Thus, surgery is fundoplication. Now, the steps of fundoplication. First of all, restore adequate intra-abdominal length, which is most important factor for Gerd. Minimum it should be 3 cm. Second is tighten diaphragmatic crura around esophagus. Third, wrap fundus around esophagus. It is called a Sue-Sign maneuver. Sue-Sign maneuver. It can be done in two ways: partial wrap or complete wrap. Complete wrap is known as Nielsen fundoplication. Nielsen fundoplication. The partial wrap is known as Dor, Toppet or Belsey mark. Dor, where 180-degree anterior wrap is done. Toppet, 180 to 270 posterior wrap. Belsey mark, 270-degree anterior wrap. 180-degree, 180 to 270-degree and 270 anterior wrap. We do laparoscopy fundoplication also. 4 to 5 ports are used for fundoplication. Now, complication of Nielsen fundoplication. Most common complication is intraoperative most common intraoperative complication is pneumothorax. In laparoscopy, we fill the tummy with carbon dioxide. When we tighten diaphragm, crura or restoring esophagus, some CO2 escape out to thoracic cavity leading to pneumothorax. Second most common overall complication is gas bloat syndrome. Tightening too much so that even gas cannot pass leads to gas bloat syndrome. So we do partial wrap or a floppy Nielsen is done.